Welcome back, doctor trainees. My name is Dr. Untara Shaikh. I'm the program director at MedSmarter USMLE Test Prep based in Atlanta, Georgia. And I will be going over the questions submitted by you on our lecture, Management of Joint Pain. So let's see what our first question is over here. The first question I have is, how is donor selected for stem cell treatment in osteoarthritis? So most stem cells intended for regenerative therapy are generally isolated either from the patient's bone marrow or from adipose tissue. To be a donor, stem cells need to match the recipient. To find out this, we need to have a blood test to look at the HLA typing and tissue typing. How often cell therapy used clinically in US and in Pakistan? So in US it's used more frequently, but in Pakistan is also making efforts in establishing this field to get desired benefits, but unfortunately the progress is very slow. But stem cell research is at its initial stages in Pakistan, and there is great need to bring government, academia, and industry together so they could make serious efforts to promote research in this very important field. This will help millions of patients suffering from incurable disorders and will also reduce economic loss. The numbers of publications from Pakistan are very less compared to developed and neighboring countries, and Pakistan also has very few numbers of institutes that are working in this area of research. What are the difficulties that the physician face in implanting the stem cell therapy? Which of the two is more efficient, platelet-rich plasma or stem cell therapy? So stem cell therapy is more powerful than PRP because as a greater concentration of growth and immune factors can be injected into the damaged area. This type of therapy is often used in areas where the body would not be able to heal itself, like we are using it in osteoarthritis. Question number 3, will you recommend PRP in arthritis and its role? Platelet-rich plasma therapy attempts to take advantage of the blood's natural healing properties to repair damaged cartilage, tendons, ligaments, muscles, or even bone. So when treating osteoarthritis with platelet-rich plasma, so we inject PRP directly into the affected joint. So the goal for that will be to reduce the pain, improve joint function, possibly slow or healthy or decrease the, even repair the damage to the cartilage. And this platelet-rich plasma is derived from a sample of the patient's own blood. The therapeutic injections contain plasma with a higher concentration of platelets that has a property of healing, growing. They have growth factors and healing factors. Okay, then it's found in the normal blood. Question number 4. What is land and water-based physical therapy? Land-based treatment includes different types of exercises that trains the aerobic ability, like strength or flexibility in a specific or general manner, like you do on land. And the water-based physical therapy is the aquatic environment that reduces the impact on joints, improves the microcirculation, facilitates relaxation, decreases the number of contractures, and improves muscle tone due to its natural resistance. So these are our water-based and physical and land-based thing. So because water works to reduce the swelling in joints, and all exercises performed in water use the total body, and you will not be sore or experience any stiffness following the water therapy session. Okay, so that's why water, doing exercises in water is really useful. Question number 5 is, why anti-inflammatory drugs are used in non-inflammatory arthritis. So let me go back to the property of the drug. Okay, so anti-inflammatory is a property of a substance or treatment that reduces inflammation or swelling. So now the question over here, they said that non-inflammatory, they doesn't have inflammation or they don't have swelling. So why are we using it? Because your anti-inflammatory drugs make up about half of the analgesics, means they reduce the pain. So that's why we use these drugs in your non-inflammatory arthritis. Question number 6. during acute exacerbations of osteoarthritis and after giving injectable corticosteroids. Should NSAID or opioid therapy already taken by the patient be continued? Yes, they need to continue that. Question number 7, guidance regarding hydrocodone dependency. So these are things that I'm going to tell you that you will see that the patient is being dependent on hydrocodone. Taking more hydrocodone or taking it for longer than intended, wanted to reduce or stop using hydrocodone, but they are failing to do so. Spending a lot of time using or recovering from using hydrocodone, experiencing cravings and urges to use hydrocodone, failing to fulfill obligations at work, home, or school because of hydrocodone use. So using hydrocodone, even when you have, that a physical or psychological problem that could have been caused or made worse by hydrocodone, needing more hydrocodone to get the effect you want, like developing the tolerance, development of withdrawal symptoms, which can be relieved by taking more hydrocodone, taking hydrocodone in any other form or method other than prescribed. Continuing to use hydrocodone even when it causes problems in relationships, giving up important social, occupational, or recreational activities because of hydrocodone use, continuing hydrocodone use even when it puts you in danger, and using hydrocodone even when they know that a physical, psychological problem and could have been made worse by the hydrocodone. Needing more hydrocodone to get the effect, developing a tolerance. Okay. So these are the symptoms that can show you that the patient is getting dependent on hydrocodone. So other part of the question was, will it be appropriate to start PPI along with NSAIDs? If NSAIDs are being prescribed for a longer period of time, then you can prescribe PPI with it. Question number 8, kindly explain the term persistent knee osteoarthritis. Persistent knee pain is an important predictor of structural joint damage and could potentially be used to predict the knee osteoarthritis earlier. So if the patient is coming with persistent knee pain, so it will give you that the joint damage has happened. Question number 9, what is the role of arthroscopy in joint pain management? Arthroscopy elevates pain in patients with osteoarthritis, but large randomized trials have suggested that arthroscopy has a limited role as a treatment of osteoarthritis. Question number 10, what is the role of knee transplant in knee osteoarthritis in elderly patients? So osteoarthritis of hip and knee is a common cause of pain and disability in elderly patients. So joint replacement surgery can elevate pain and it can restore function, but is also associated with risk and discomfort. Question number 11, what is the best physical exercise after knee transplant involving meniscus and ACL? So I'm going to show you some pictures over here. These are just the examples, but we need to start walking also for a little bit and using the cane or the walker, and they can start with their build up their stamina and start from there. So we have quadricep sets, number 1, then we have straight leg raise test, exercise, ankle pump, knee straightening exercises, bed supported knee bend. So these are all different exercises the patient can do. Question number 12 and 13. So for osteoarthritis, what is the dosage of glucosamine, chondroitin sulfate, and hydronate? How long drug treatment lasts, if it for weeks, months, or during exhibitions only, or for lifetime? If yes, it is continuous therapy or intermittent therapy. So glucosamine has shown some protective benefit for knee osteoarthritis in up to 70% of the patients, okay, in divided doses of 1,000 to and 1,500 milligram per day. So glucosamine is frequently we add chondroitin sulfate in doses of 500 to 400 milligram 3 times per day. It needs to be taken for at least 2 months for the effect, because remember in the lecture I told you it takes them about very slowly it starts working. If adult has reduction in joint pain, recommend continuing on a maintenance dose of at least one tablet a day if they don't have any side effects or nothing, because they rarely have side effects, so you're going to tell them to continue. But if there is no benefit, recommend after 2 to 3 months to stop taking the glucosamine and chondroitin sulfate supplements. You don't need to tell them to continue it without any reason. Question number 14. What is the alternative for chondroitin sulfate as one is allergic to crustacean? So this is what they said, that this our chondroitin sulfate is derived from shellfish. Okay, shellfish is the one that if patient is allergic to that, they cannot take it. So patient who is allergic to that, we have vegan drive resource is coming from corn fermentation. So we will be prescribing that or suggesting the patient to take it. But there is a small amount of sugar in glucosamine, and this can elevate blood sugar, so patient with diabetes needs to be aware of that also. Question number 15. What is the role of omega-3 fatty and curcumin acid and fish oil in joint pain? How to prescribe it? So these are different doses that, and then they can get it over the counter. Omega-3 fatty acids, they need to take it about 2 to 4 grams. And what it does, it increases the blood flow throughout the body, which can help reduce joint pain and swallowing. Curcumin, this is your 500 milligram orally up to twice daily, has been shown to have some anti-inflammatory. So it's your turmeric kind of thing. So that has anti-inflammatory role. Fish oil, 1 to 3 gram per day, can help reduce the intensity of joint symptoms like morning stiffness, tenderness, swelling, and discomfort. So these are the thing. How to prescribe it? These are the doses that you can tell your patient to get it from the market, or you can prescribe it to take it over, from the pharmacy. Number 16, does glycerin have some role in joint health? How long it should be taken? So how does it work? It works by blocking the action of interleukin-1 beta. This is the interleukin, this is the protein that involved in inflammation and destruction of cartilage. Okay, so what it does, it blocks that. So when it blocks this interleukin-1, so it helps us in the helping the elevating the symptoms of osteoarthritis. So how long should it take? You can take it as long as you want, but if the patient develops diarrhea, then they need to stop this drug. Question number 17. As a GP, patient usually asks for role of massage with oil. Is it helpful, or we should discourage it? Massage therapy can be relaxing and soothing, or rough and intense, depending on the type of the massages involved. Okay, but massage is often used to relieve common symptoms of many types of arthritis, like we have reducing pain and stiffness, easing anxiety, improving range of motion in the joints, and promoting more restful sleep. So it's a good thing that you promote them to use it. Question number 18. Role of local application of painkillers, gels, how should we prescribe it? So active ingredients in over-the-counter topical pain medications are the one they help us. Okay, let's say for example we have capsaicin. Capsaicin is the one that depletes the nerve cells of a chemical that's important for sending the pain messages. Okay, so capsaicin is most effective if used several times a day. It might take up to 2 weeks to relieve the pain. And salicylates, they contain the pain-relieving substance that found in aspirin. We have Cream or Bengay. These are the examples. The third type we have over here is counter irritants, substances such as menthol and camphor. They produce a sensation of heat or hot or cold that may temporarily override the ability to feel arthritis pain. And that example is icy, hot, or biofreeze. Then we have anesthetics. So these anesthetics are the one, they are like lidocaine. They produce numb sensation to reduce pain. Lidocaine is available in the form of cream, gel, spray, or patch, and it can Lidopatch and lidocaine. Question number 19. Which one is more helpful, hot therapy or cold for monoarticular joint involvement? Are their indications different? So these depends on what patient is trying to achieve. Okay, so heat can relax muscles and help lubricate the joints. Maybe used to relieve muscle and joint stiffness, help warm up joints before activity, or ease a muscle spasm. So if patient wants to start the activity So they need to warm the joint. The cold, on the other hand, is the one that reduces the inflammation and swelling and pain related to arthritis activity. Okay, so also we can use the cold therapy in acute injuries. Question number 20, is it worth it giving hyaluronic acid shots to a patient of osteoarthritis with knee joint stiffness? If yes, what points should be kept in mind about its efficacies and pros and cons? So there is one pros that the advantage of this one is that relief may last from 3 to 6 months. Okay, but this is the injections have shown that they relieve the pain and swelling, but it's not immediate, so it takes about 5 weeks before the patient feel the full effects of the treatment. And the potential side effects are the one that's mild injection site skin reaction, and they have arthritis flare up immediately following the injection, and hyaluronic acid injections are administered differently depending on the manufacturer or preparation being used. Some require one injection and others require several injections given weekly. There was one question, I think about like 13 and 14, they were also asking about the dosage of hyaluronic acid. That's why I didn't answer over there. Over here, the answer is depending on the manufacturer, the dose will be continued. Question number 21. What is the safe analgesics in chronic kidney disease patient in acute and severe joint pain? Safe non-opioid options for pain management in renally impaired and dialysis patients include acetaminophen, certain NSAIDs like such as ibuprofen, fentanyl, hydrocodone, hydromorphone are the safest opioids to use in renally impaired and dialysis patients, but long-term use of NSAIDs should be avoided. Answers to question number 22 and 23. In monoarthritis, do we start antibiotic only after confirmation by cyanovial fluid analysis, or can we start it in clinical suspicion due to signs of inflammation? And can we aspirate an acutely inflamed joint? So yes, what we're going to do is before the cultures come back, so you can start the antibiotic, empirical and antibiotic, that's known as, and when the culture is back, the fluid analysis is back, and then you will direct the antibiotics towards that, and you can aspirate an acutely inflamed joint. Second part of this is what is the initial antibiotic we can start. So like I said, empirical and its dose, and then patient should be referred to consultant. So dose depends on different things. So we will refer to the consultant when it's recurrent attacks of joint pains will be there. Question number 24, for the patients of psoriasis who has developed knee pain and difficulty in walking, what is the best management plan? So in the next slide, I will be showing you that if methotrexate is safe, the second part of it, yes, it's safe other than the contraindication. So pregnancy, hepatitis B, C, hepatotoxicity, hepatotoxic drug is the contraindication. So we are not going to use in these conditions. If knee replacement surgery recommended, yes, it is recommended. So this is how you will start. If the patient comes with pain, so we start with NSAIDs, and then we start with intra-articular injection. If that's not working, then we give them synthetic D.U.H.S. That's your methotrexate. If methotrexate is not being helpful, then we add on to anti-tumor necrosis factors like etanercept. Like I had told you in osteoarthritis, in rheumatoid arthritis management, this is the same like for that too also. Same thing, DMARDs are being used in biological and anti-tumor necrosis factor inhibitors are being used. So if you remember from the previous lecture, what was tumor necrosis factor was doing, it was keeping the granuloma intact, right? It was walled off. So if you give them anti-tumor necrosis factor inhibitors, so what will happen? It will destroy that tumor necrosis factor and TB will be active. So before you give them these drugs, you need to do PPD testing to confirm about the latent TB. And before you give the methotrexate, you need to make sure that patient doesn't have any renal insufficiency, liver conditions, or pregnancy and hepatitis B and C. Question number 25. How can obese patients exercise to reduce weight and will aggravate? So see, this is very common thing. How they can do it? They can do water-based exercises. Remember, I just told you that water-based exercises, what they do, they have no friction. Okay, they make it easier for the patient, and they need to control their diet, and they can do wearable walking. So I hope these all have answered your questions, and I would like to thank the following trainees for their questions. And these are our lot of different nice doctors. Then we have our following trainees for their support in the question and answer screening process. That's Dr. Nabila Khan and Aisha Imran, Faiza Ali, and Alia Atif. Good luck and happy studying to all of you.